Thanks a lot, Dr. Animesh. It was a great presentation. I'll be now talking about scleral buckling, whether it should be the first choice for all primary retinal detachments. I have no financial interest. Now, scleral buckling was considered the gold standard for surgery for uncomplicated retinal detachment all along. However, there has been a growing shift towards pars plana vitrectomy. A 2017 study showed that 83% of preference was vitrectomy, while 5% for scleral buckling in cases of retinal detachment. Now, why this decline? It will be covered in details by Dr. Devakant. I'll just touch upon a little bit upon it. The availability of small gauge instrumentation has made vitrectomy a great option. Also, less time is spent on scleral buckling by mentors and trainee programs. There are economic and time factors. There is no industry support for scleral buckling, and certain misconceptions have creeped in. These include the misconception that scleral buckling actually has a lower success rate than pars plana vitrectomy, has a high complication rate, and a high rate of PVR. There is no dearth of studies actually where it is shown that scleral buckling is actually as effective as primary vitrectomy, not just in phakic patients, but also in pseudophakic and aphakic patients. When combined with a pneumatic retinopexy, the success rate goes up even higher. There is also a Cochrane review where 10 randomized controlled trials were taken and a review was done. And there was very little difference between pars plana vitrectomy and scleral buckling noted, regardless of the type of aphakic or phakic status. Now, in spite of that, today the picture is that scleral buckling should be done only for young phakic patient with no PVD. So with this background, I come to the purpose of this presentation. It was to evaluate whether the indications of scleral buckling can be extended beyond a few selective cases and whether there is any relevance of this procedure in modern day practice. We did a retrospective study in our center. We included 73 eyes of 71 patients. We included all kinds of retinal detachments, primary retinal detachments, that is phakic retinal detachment without PVD, phakic detachment with PVD, pseudophakic detachments with PVD, aphakic detachments, and complicated detachments where there was a very posterior break, or patients with choroidal detachments, patients with retinoschisis, also with a fixed fold in one fold. Now, coming to the surgical procedure, this was a 72-year-old gentleman with a bullous retinal detachment. Patient was pseudophakic. So we'll just touch upon the surgical procedure one more time. As Dr. Animesh mentioned, we do a 360-degree peritomy followed by isolation of all the 4 rectus muscles. Again, hooking has to be very careful. We then go ahead with the cryopexy and marking of the break. This is done using indirect ophthalmoscopy. Now, one very important step is to actually mark the break using a scleral marker, so that even after you have done the cryo, when you actually go ahead to place the buckle, you have actually a mark on the scleral surface so that the buckle placement can be done without any hitch. Once the cryo is done, we go ahead with the placement of the buckle. As you can see over there, this violet mark indicates the area where the break is. We go ahead with Ethibond sutures and the buckle is sutured tightly in place. I always put in a 360-degree encerclage using a 240 band. Scleral tunnels are used to actually fix the encircling 240 band, and scleral tunnels are made in all the 4 quadrants, all the 3 quadrants that is other than the buckle. This is followed by passing the encerclage through the scleral tunnels, through the groove of the buckle and the recti muscles. It is then tightened using a Watzke sleeve. Now, there is a question which we get asked is how much to tighten. I'll be discussing it in a subsequent slide. We then go ahead with the SRF drainage. And it's always important to maintain pressure during the SRF drainage because that would prevent any subretinal hemorrhage. The conjunctiva is then sutured up. The muscles isolation muscles are removed, and with that we complete the surgery. Now, how much to shorten the band? For this, we have to go back to our school days. I'll be reminded of our geometry classes when we used to study that circumference is basically twice pi r. So we are trying to reduce the circumference of the eye. So the new circumference will be twice pi r minus 1 if we desire an indentation of only 1 millimeter. So the idea here is that irrespective of the size of the globe, the amount which we have to reduce does not depend on the initial size of the globe. So basically, for indentation of 1 millimeter, we go for just twice pi, that is 6 millimeter of shortening. For indentation of 2 millimeter, we go for a 12 millimeter shortening. So this patient did fairly well post surgery. This was around 2 months after surgery. He had a visual acuity of 624. Now we go ahead and see the buckling procedure in an aphakic patient. So the process is basically the same. It's initial peritomy followed by isolation of muscle. Then we go ahead with the cryopexy. It's basically a very similar process even for aphakic patients. The explant is put in place, and we have to make sure that the buccal actually covers the break. We use AT-bond suture. These are basically non-absorbable sutures, which will keep the buccal in place. The rest of the steps remaining the same. We go for a scleral tunnel in the other quadrants and put in an encircling band. Now, the interesting thing is, even in an aphakic patient, you can actually go for a drainage of the subretinal fluid. Once that is done, we evaluate the retina to see whether everything is in place, and then the case is completed. This patient also did fairly well post-surgery and regained a vision of 6/9. Another thing which I have found very useful is using air injection, especially after a globe has become very soft. We try to put one bubble. However, that was not the case in this particular patient. Eventually, I was able to get a single large bubble. So that provides some amount of tamponade. In case you are not going for a drainage procedure, especially in a superior break and superior detachment, we can actually do a little bit of vitrectomy. This was a pseudophakic patient, as you can see. You use a cutter through a MVR port to remove some amount of vitreous. The eye is softened, and then we go ahead with putting in an air bubble. So that will provide tamponade till the retina settles down. In this particular case, I did get a large single bubble. At the end, the port can be sutured off. These are a couple of cases. This is a patient with a fixed fold in one quadrant. Even though patient had a fixed fold, as you can see, the retina settled down very well with the scleral buccal, and the fixed fold actually remained on top of the buccal. These are a couple of other cases where a scleral buckling did a very great job. This is a pretty interesting case. As you can see, this is a fixed fold very close to the fovea, and the patient had a large dialysis. I still went ahead with a scleral buckling, and after 2 weeks, the patient had a fairly attached retina, decent improvement in vision, and as you can see, the star fold was actually opening up. One interesting thing which I noted was this patient still had an open break. The break was on top of the buccal, but it was still open, and the retina was still attached. So I went ahead and did a little bit of a barrage laser. A couple of months later, the star fold is almost gone completely. The break is still open. You can see the laser marks over here. But I was still not satisfied and did a row of further laser. So there is a very interesting study done by Wong et al., which was published in Eye in 2018, which showed that even in cases where the break remains open, after a scleral buccal, the intraocular currents change, and through Bernoulli's principle, that actually helps in drainage of the fluid from the break. So that leads to attached retina even when the break may remain open. So that's a very interesting thing. Okay, now pushing the boundaries of scleral buckling. This was a very posterior break, as you can see, with a rolled edge, indicating some amount of PVR. Now, I still went ahead with the scleral buccal, although the break was not completely on the buccal, but it still remained attached, and the patient's visual acuity improved quite a lot. So to summarize the results, mean age of the patients was 47.4 years, and single surgery primary retinal reattachment rate was pretty high, 94.5%. 4 patients required resurgery, that is pars plana vitrectomy, and they had a successful retinal reattachment. There was a significant visual improvement in all the patients. One important thing to mention is that it's easier to fix a scleral buccal failure than pars plana vitrectomy failure. And even though considered less effective, scleral buccal can actually be pretty useful. Although one important thing is scleral buckling does induce significant myopia. And in our study, we had a myopia which ranged from -3 to -5. There are certain advantages. Accommodation is preserved in young patients, and in older patients, vitreous is preserved. There is no need for post-operative patient positioning, unless, of course, you are injecting some air inside. And surgery is also a lot cheaper than vas vena vitrectomy. So to conclude, it's a cheap, affordable, reliable option, offers early visual recovery after a single surgery, and I believe it should be the first choice for all primary recurrence retinal detachments. Thank you very much.